Lovely. Over to you, Shashi.
All right. Can everyone hear me? Yeah.
Yes, we can hear you.
So today we're going to present an interesting trial. This was done in Australia and New Zealand. It's the Icurox trial. Basically, they compared conservative oxygen therapy during mechanical ventilation in intensive care. Alex, can you go to next? Yeah. So we all know traditionally, like oxygen therapy is considered like harmless adjunct. Last years, probably in the last 4, 5 or 6 years, the concept have changed a bit. So we treat it as a intervention than just taken for granted. So we do give quite a lot of thought before giving anyone some oxygen. So is hyperoxia good? So probably not. Can anyone tell me what are the problems with hyperoxia? If you can unmute and talk about it.
So, superoxide injury can occur, like free radical.
Okay, yeah. So that's one of the mechanism of problems with hyperoxia. Yeah.
There are some, I think, neurological symptoms and also some cardiovascular symptoms that occur with hyperoxia.
Yeah,
like
you're right.
Pulmonary. So if it's like, if you're trying to give it to neonates, then fibrolental, that fibroplasia or retrolental fibroplasia that occurs. If you're trying to give it to adult patients, then some sort of an atelectasis occurs with high oxygen therapy. I can't recall the name of that thing. Yeah,
that's fine. That's fine. Alex, can you go to the next slide? Yeah. So you're right. I think there are a lot of changes with occurs with hyperoxia. So there can be like pulmonary toxicity or CNS toxicity. So there can be increased pulmonary toxicity, and then it can increase oxygen. Basically, reduces the hypoxic pulmonary vasoconstriction, so which alters the VQ relationship and basically does the worst thing which could happen: diverts the blood from the better ventilated lungs to lungs which are not well ventilated and increases dead space. It also causes some absorption atelectasis. Will be rightly said. It causes some atelectasis. Also causes inflammation and pulmonary edema. It also causes vascular vasoconstrictions. It affects both systemic blood vessels and coronary vessels as well, and reduces cardiac output. And all this free radical generated can cause CNS toxicity as well. So it can cause delayed cerebral ischemias post injury, subarachnoid hemorrhage, or any brain injury. It can also cause seizures and also cause cerebral vasoconstriction. Yeah. All right, next slide. So how much oxygen do we need? So this has been like $1 million question. Like, so no one knows exactly how much oxygen. We always keep titrating the FiO2 in our ventilated patients. So that's why they're trying to find out how much we should give. So there have been a few trials in the past. So I'll just go through these trials. So there was, in 2015, there was an interesting trial amongst patients who were undergoing PCIs post-STEMI. So this VOID trial, they demonstrated no benefit in giving oxygen to normoxic patients. But if patients are having an MI and having a normal oxygen, so they demonstrated there was no benefit in giving any extra oxygen. Then there was this oxygen ICU trial, which was quite popular and quite talked about in 2016, which found a striking mortality benefit in those critically ill patients who were given a conservative oxygen regime. Then there were lots of stroke trials, the largest being this SO2S trial. They suggested that conservative oxygen therapy is non-inferior to a liberal strategy. Then there was a gentleman named Herman Horst. He did lots of studies on conservative and and liberal strategies. So he published an article in 2017, where he defined severe hyperoxia as PO2 more than 26 kilopascals, which was associated with higher mortality rates and a fewer ventilator-free days in comparison to mild hyperoxia, where he defined mild hyperoxia as PO2 between 15 to 26 kilopascal. It does feel a bit generous when you take those values, 15 to 26. Then there was this D2O2X trial in acute myocardial infarction patients by Hoffman, which showed no difference in 1-year mortality between RUMAD and oxygen therapy normoxic patients with suspected acute myocardial infarction. Then there was an article in 2018 which found that there was no association between hyperoxia and increased mortality in emergency department. So you can see it's been compared in both intensive care, cardiology, and critical care, the benefits of oxygen. In 2018, there was a very big meta-analysis by IOTA group, which suggested that in a heterogeneous group of ICU patients, the hyperoxia increased mortality, though they were a bit too focused on the oxygen ICU trial, which was probably skewed the results of the meta-analysis. Go to the next page. After that, in around 2018, there was a very controversial recommendation by WHO, which said that all adult patients undergoing general anesthesia with ET tube for surgical procedure should receive 80% FiO2 intra-op, and then, if feasible, immediate post-op for 2 to 6 hours. Well, the rationale for it was that these measures improve the oxidative killing of bacteria by neutrophils and reduces the surgical site infections. The rationale was fair, but then there was insufficient evidence on methodology limited with these studies, and they completely ignored the hyperoxic effects of the ventilation, which was probably didn't give us the right results for the study, actually. Can you go to the next slide, Alex? So apart from this, there are a few more studies which had like conflicting results, and the use of oxygen in different groups of patients was studied. So there was a study in cardiac arrest patients where one group of physicians showed that there is a decreased survival with a conservative oxygen therapy, while there's another group which did not find any difference. The same was with patients with traumatic brain injury. So in this group of physicians, Asher and his group, they found there was a reduced mortality with hyperoxia, while there was opposite was shown with Davis et al. And there were a few more studies published between 2011 to 2015, which compared the association of hyperoxia with cardiac arrest, traumatic brain injury. So they found an association between arterial hyperoxia and delayed cerebral ischemia and poor cerebral performance, disability, and hospital mortality in patients post-cardiac arrest and traumatic brain injury and stroke. So these are the few studies I tried to compile before we talk about the Icurox trial. So so Icurox, what they basically did is that they tried to had a primary outcome as when they tried to compare the effects of the conservative oxygen therapy to usual liberal oxygen therapy, and they compared the number of ventilator-free days from randomization till day 28. So the study design is basically they included intensive care unit in 21 ICUs in Australia and New Zealand, and they enrolled patients between September 2015 to May 2018. It was an investigator-initiated parallel group and randomized clinical trial. It was single-blinded. Though the clinicians were not blinded, but the outcome assessors were blinded. There was a random computer-generated allocation This was the intention to treat analysis. They tried to recruit 1,000 adult patients anticipated to require mechanical ventilation beyond the day after recruitment in intensive care. So there are a lot of exclusion criteria, but the inclusion criteria were pretty much standard. They try to include anyone who's an adult age group, anyone who's expected to receive mechanical ventilation in ICU beyond the day of recruitment. So this was randomized, the patients were randomized less than 2 hours after initiation of mechanical ventilations. Patients or their surrogates provided consent. Exclusion criteria were quite a lot, because that kind of skews the data if you don't exclude these patients. So any patients whose hyperoxia was clinically indicated, like carbon monoxide poisoning or any other patients who require hyperbaric oxygen, these patients were excluded. Patients with COPD or patients who had a previous exposure to bleomycin or a chronic type 2 respiratory failure patient, they were excluded. Pregnancy, patients whom the death was inevitable, patients whom life expectancy was less than 90 days, patients with drug overdose, patients with long-term dependence on invasive ventilations, patients with Guillain-Barré syndrome, patients with muscular dystrophy, motor neuron disease, these patients were excluded. Fine, next slide. So what were the methods? So there were two groups. So there was a conservative oxygen group and the usual oxygen group. So in conservative oxygen group, you see that they try to target the saturations between 91 to 96%. So at any point in time, saturation touches more than 97%. It was treated as an emergency, and then FiO2 was reduced by 10% every 5 minutes till we get the saturations to less than 97%. While in the control group, there was no upper limit for saturations. So any saturations more than 90% were allowed, and any FiO2 less than 30% were discouraged in this group. So this is like a good summary of what they did during this study. So you can see that on the conservative oxygen group and the usual oxygen group. So you usually try to get the FiO2 as low to 0.21% in the conservative oxygen group, and reduce FiO2 to every 10% if it's basically going above 97%. So that there was a too low alarm as well. I mean, the low limit of saturation should be determined by the treating clinicians. So usually the target was more than 91%. So if they said if the saturation falls below the target range due to decrease, they immediately used to return to previous FiO2 level. While the usual oxygen therapy was pretty much similar to what we normally do in intensive care. Like, so there was no upper limit for oxygen. The only difference was they tried to discourage any reduction in FiO2 to less than 30% in this control group. Next slide, please. So there are a few things which are common to both groups, like minimum saturation 90% in most patients. Other aspects of care like weaning, extubation, they were all at the discretion of clinician. There was no restriction in oxygen when patients were transported outside intensive care. Any increase in FiO2 for standard procedures like bronchoscopy, suctioning, and tracheostomy were followed. And while patients who needed ECMO, they used our usual oxygen therapy for them. So these patients were and this assigned oxygen therapy strategy until discharge from ICU or 28 days of randomization was observed, whichever was earlier. Like, so they used ventilator-free days were assumed to be 16.4 plus or minus 11.3 days. And the absolute difference of the ventilator-free days was about 2.6 day 28. So they tried to enroll 1,000 patients for a 90% power for this study. As I said before, this analysis was the intention to treat basis because no patients were left with less oxygen for any unknown reason. Next slide, please. So this is basically how they enroll patients. So they were almost 3,300 patients who were met the inclusion criteria. Then they excluded a few, and 1,000 out of them, 1,000 underwent randomization. About 499 were assigned to conservative group, and about 501 were assigned to the usual oxygen therapy. As you can see, the demographics are pretty much similar in both groups. Out of that, only 492 received the assigned intervention, 7 withdrew consent. The similar numbers on the control group as well, 494 received the interventions. And in the end, there were so few more inclusions after the initial consent. So totally there were 484 on the conservative group and 481 in the control group. Next slide. Alex, do you want to take over from there, or do you want to?
Yes, I can take over from here.
Yeah.
So here, this slide is essentially just patient characteristics at baseline, and broadly speaking, they were pretty well matched, as you can see. If we look at the primary outcome, so the primary outcome of the study was that conservative oxygen therapy did not increase the number of ventilator-free days at 28 days when compared with usual oxygen therapy. And if we look at secondary outcomes, again, conservative versus usual, there were no significant findings in any of the secondary outcomes. So no real difference in 90-day mortality, in 180-day mortality, in cognitive function score at 180 days, in health-related quality of life, which was a survey that they did on all patients at 180 days, and also at employment status compared to baseline. So no significant findings in any of the outcomes. I think it is interesting though, when you look at some of the secondary outcomes and what they decided to test. So looking at a more diverse group of secondary outcomes. So in terms of obviously cognitive function and employment status. And here is that in the table from the study, essentially showing the same thing. However, if we look at the subgroup analysis, there were some interesting things shown up. So in the subgroup of patients with ischemic hypoxic encephalopathy, patients were found to benefit from conservative versus normal oxygen strategy. And that was statistically significant. So at day 180 in the IHE group, 43% in conservative group had died versus 59% in the normal oxygen. And the conservative group also had better neurological outcomes. In patients who had acute brain pathologies other than IHE, they appeared to do better with normal oxygen, and patients with sepsis also did better in the usual care oxygen group. So the strengths of the trial, it's clinically relevant, and it's clinically relevant because it's something that we do to all of our mechanically ventilated patients. We make a choice about what oxygen, what PaO2 or SATs we're going to target, and consequently what level of FiO2 we're going to choose. We know that hyperoxemia and hypoxia are harmful, so it's just a question of what risks we accept when we choose that FiO2. It is the largest trial to ask this question. So it was done across 24 intensive care units, and 3,300 patients met the inclusion criteria. It was a multi-center RCT. The study was well designed to avoid bias and confounders. So it used allocation concealment, which avoids selection bias. Full blinding was not possible, obviously, because the clinicians in charge had to choose what FiO2 we were given. It used an intention to treat analysis, and patients were completely followed up. In terms of asking the question which it wanted to ask, the study managed to do that. If we look at the figures, the conservative group spent a median duration of 29 hours with an FiO2 of 0.21 versus 1 hour of 0.21 in the normal oxygen group. So that's a fairly significant difference. The conservative group also had less time with SATs more than 97%. So that's 27 hours versus 49 hours. And as I've already mentioned, I think the range of secondary outcomes is a good thing in this trial, looking at employment status and cognitive function as well. And this is what I was talking about. So in terms of asking the question which the study posed, you can see that conservative oxygen and usual oxygen were suitably separated in a number of areas. In terms of weaknesses, obviously clinicians were necessarily unblinded, and therefore there is the potential for bias to creep in there. For example, when choosing when to extubate a patient and when to wean a patient, and in things like oxygen targets. Another criticism is that the normal or usual oxygen group didn't use FiO2 at particularly high concentrations, certainly not in as high concentrations as maybe we use on our unit or the other units use around the world. Even though it was a large study, it may not have been large enough because, well, as we saw, we didn't generate any statistically significant findings in the outcomes, and potentially, if the study was larger, we might have been able to do that. Some data was missing in the quality of life and cognition results, and the exclusion criteria removed some very sick patients where it may have been useful to see whether a conservative oxygen strategy would have helped. So in terms of discussion, so the subgroup analysis is hypothesis generating because in patients with IHE, it seems like it could be significant to target a lower oxygen strategy. Overall, although it wasn't statistically significant, it does show that there is an absence of harm in a lower FiO2 strategy. And we can go even further and we can say that we suspect it may be beneficial for patients. Obviously, we don't have the evidence from this trial, but it's fair to say that we suspect that based upon scientific plausibility. It certainly reduces the cost for patients or for the unit in terms of having to supply oxygen. Again, something that may be worth considering in COVID times when oxygen demands, obviously, well, in some places around the country, became very close to critical. Will it change the way that we work? Maybe. I think we're already quite conscious that too much oxygen can sometimes be detrimental. But this study may just cause us to pause and think again. In terms of what's next, so they are continuing with trials. So there's Hyperoxia which is New Zealand, Australia, ICS endorsed mega randomized registry trial looking at a similar thing. And there is the UK ROX coming up, which will be doing a similar thing in the UK. Are there any questions?
Hi, it's Livia here. I couldn't see in your chart what sort of, when they said sort of conservative oxygenation, what was their target?
So they targeted, they try to maintain saturation between 91 to 96%. Any patient the saturations hit more than 97%, they try to get it down to less than 97%. So that's a target range.
Okay, so 91, 96. Okay. But they didn't mention any PO2, so they never did a PO2 test at any point? Or result equivalent?
I'm not sure if I saw that.
Yet. I didn't see that.
Yeah, it was more of based on saturations. Yeah.
Mm-hmm.
So that's interesting, because if you look at that, sometimes when you say sometimes very conservative, almost hypoxic levels that we aim for, where we go for SAT of 88% and above. Do you know of any evidence if there's any difference if we aim for any lower? So I guess they would define as being hypoxic at 88%?
Yeah, probably for this study, they tried and excluded all patients with COPD or hypercapnic respiratory failures. So that probably a lower so that's why they maintain saturations above 91% in most patients. But I'm not aware of any study where they probably got it down to 88% with patients who don't have any underlying COPD. So that'll be interesting. Yeah, probably, yeah. Yeah, I couldn't find any of those. I mean, I probably didn't look in that detail whether in ARDS patients, whether they're taking that as a lower oxygen therapy. Remember what cutoff they're taking it for conservative oxygen therapy in those patients. Yeah, probably something we can look at in the literature.
I think we're about to do the UK ROX here.
Mm-hmm.
Yeah. So do you know, Liv, about what are the targets on the UK ROX? I haven't had a chance to look.
No, I haven't seen it yet. I think the research people here are looking into it. So viability of doing it.
Nice.
So we will. So once it comes in, I'm sure all of you will be informed, and we'll all get involved in that as well.
Yeah. That'll be interesting. Yeah.
Okay, thank you very much. If anyone else has any questions, well done. Thanks, guys.
Thank you.
Thank you.
Thanks, guys. Thank you.
Guidance.